Dr. McBride. I am the interim educator for DI currently. So I think I know everybody, but just in case. Okay, so today we are going to talk about a few different things. We're going to talk about some of the legislature that covers ultrasound and the different controlled acts that we're authorized to do. As well, we're going to talk about the medical directive that's been updated to include the transvaginal probe insertion. And we're going to talk about the SOP. I'm going to talk a little bit about equipment, the quality control and infection control practices, and Dr. Bruni is going to talk about the imaging and the technical considerations for that. Okay. All right. So first thing is the Regulated Health Professions Act is our main legislature that identifies the controlled acts that any of the regulated health professionals can do in Ontario. So what is a controlled act? You can see that it lists 14 different acts that we could do. And what gets included as a controlled act is anything that has the potential to cause harm or pose a risk to the public or our patient if it is done by an unqualified person. So I'm going to just skip to the next slide. So for us as technologists, it's really the Medical Radiation and Imaging Technology Act that lets us know which of these controlled acts, which of the 14 that we as imaging technologists are authorized to do. And that, of course, is dependent on us having the knowledge, skill, and judgment to be able to do so. So for this talk, the ones that we are really looking at that we are authorized to do is number 3, and it's going to be putting an instrument beyond the labia majora, as well as applying a prescribed form of energy. Okay, and for us, it's diagnostic ultrasound is one of the forms of energy, of which there's many. I also wanted to point out that for acts 1 to 4, they require an order from a physician, whereas, of course, act 5, it could be anybody who's authorized under their own, a professional act who can do it. So a nurse practitioner, for example, under the College of Nursing Act can apply a form of prescribed form of energy. Okay, I also want to point out, because this is included in our SOP, that under the Regulated Health Professions Act, there is an exemption so that students can also perform these controlled acts, even though they're not yet regulated. And the exemption specifies that it must be done under the supervision and direction of someone who is regulated and authorized to do these, a member of the profession. So as you're going to be able to see later in our SOP, the students will have to observe 5 actual transvag probe insertions first before attempting one on their own. And for any of the probe insertions done by a student, they do need to be directly supervised by a sonographer. And as well, the CEL will review all the applicable SOPs and documentation with the student prior to that.
This meeting is being recorded.
Does anybody have any questions so far on the legislation? Sorry, I've seen some comments in the chat. Okay, they're just giving attendance. Okay, so we are going to talk about the medical directive. Medical Directive 3-003 is not new, but our previous versions of it only included initiating an order for the insertion of an IV. With this update, which is not posted yet on Paradigm, but it has been approved by all of the corporate committees, we have included now the other controlled acts that also require orders by a physician, and that's the transvag probe insertion, as well as a rectal tube insertion or a tube into an artificial opening of the body. On the slide, there you go. So what is a medical directive, first of all? Because I know some people are a little bit unsure of what that is. So it's really an order given in advance by someone who is authorized. So in this case, all 43 radiologists have already signed off on this order. And then there's certain conditions that must be met in any directive. Okay. This is different. A lot of people sometimes get a little bit confused between a medical directive and a delegation. So a delegation is when somebody who is authorized to perform one of those 14 controlled acts delegates that authority to somebody else. And then they have that authority themselves. And it still goes through all the same committees as the medical directives, but a medical directive is really your order, and it's like it's pre-signed, and you are just implementing that order on their behalf. Okay, so although this medical directive includes, as I said, the 4 different orders, one for IV, the transvaginal probe insertion, the rectal tube, and the tube into the artificial opening body, for this presentation and this slide, I've only drawn out the parts that are relevant to you guys for the transvaginal probe insertion. So this is the order to insert the probe. If you remember back on the beginning slides, any of those controlled acts do require an order from a physician. The recipient patients are any adult or pediatric patient who presents to DI and does require a transvaginal probe insertion as part of their imaging. And the reason there is pediatric in here as well is because Trillium defines pediatric as anybody who is 18 and under, or under 18. So the people who are allowed to implement it is you guys, the sonographers who work in DI at Trillium. The indications to be able to implement this order is that there has to be already in place an order for an ultrasound of the pelvis from someone who's authorized to order that. And according to our DI SOP or protocol, they require transvaginal images to be done. The only contraindication to actually being able to order the probe insertion is a refusal of consent from the patient. If any of these conditions are not met, then the sonographer will consult the radiologist, who could always do this order and complete that for them. So most documentation for medical directives, you need to actually pick the order mode medical directive. We're going to do this a little bit different for the transvaginal probe, just because it's not kind of in isolation of the actual exam. So what we're going to do, if you look at the bottom, is first of all, if you change the order, so you had just an ultrasound pelvis order and you changed it to include the transvag, then when you change the exam, there's a comment section, and there you would write the medical directive number and the radiologist who's supervising, just in the comments. Other than that, you will also document it, and it can be in the begin or the end exam navigator, but the notes section, you're going to document them. If you inserted the probe yourself as a sonographer, you're going to write the medical directive number and again the name of the radiologist who's supervising. If by chance, because we'll look in the SOP, you're going to ask the patient if they would prefer to do it themselves, and if they say yes, then your note will say that the patient inserted the probe themselves, and you will also document that they completed hand hygiene prior to inserting that probe. Any questions on that part? Okay, so we're going through this quickly. Let's talk about the actual SOP. So first of all, the purpose of the SOP is to provide the sonographers instructions on how to perform the probe insertion as well as complete the ultrasound examination. There are a few requirements for this SOP, and most SOPs actually don't have a lot of requirements, but this one has a number of them. So first of all, you need to verify that a transvag exam is indicated for that patient. Again, you need to ask the patient if they would prefer to insert the probe themselves versus you do it for them. If they do want to insert it themselves, they must complete hand hygiene as per our Trillium policy, which is the hand hygiene for all healthcare workers, patients, and visitors policy and procedure. And again, the best practice is, unless the hands are visibly soiled, to use an alcohol-based hand sanitizer. If they are visibly soiled, soap and water is the best practice for hand hygiene. If it is a male sonographer, They will require a female chaperone, the same gender as the patient. They need to be a staff member, and the very first choice as a chaperone is another technologist. It does not, or at least a regulated health profession, so that could also be a nurse. It does not need to be a sonographer necessarily, but someone who is familiar with what this procedure would entail. So if a patient has never been sexually active or has stitches or episiotomy, they will use their clinical judgment and may consult a radiologist or the ordering physician prior to performing the probe insertion. One of the contraindications to doing a transvag examination is if the patient has active bleeding associated with a known placenta previa or premature rupture of their membranes. Okay, so that's really the only contraindication to doing this other than a lack of consent from the patient. We will be documenting competency assessment on this, and this is still to be worked out with COVID. We were going to be using the SIM pelvis, so we might still go that way, or it might be an observation by the charge techs. And again, students must observe 5 insertions before they're able to try one on their own, and any insertion performed by a student must be directly supervised by a sonographer. Like anything with the quality control, you will need to check the reprocessing tag and label to confirm that the high-level disinfection has been completed, and the documentation of that info will be put into the patient's chart in PACS and also the reprocessing logbook. So the infection control piece is not actually in the SOP, in the requirements section. It's more in the steps of the actual procedure, but I wanted to pull it out to highlight the best practices for IPAC. So always perform hand hygiene, wear disposable gloves before inserting the probe. Once again, if a patient is inserting the probe themselves, they must complete hand hygiene just before putting the probe in. Cover the probe with a condom. Use a single-use package lubrication on the outside of the condom-covered probe. And if the probe comes into contact with the rectum, or even if you suspect that it might have come into contact with the rectum, it is considered soiled, and you must exchange that probe for a clean probe. And we're going to go through the procedure steps on that, where you would basically start everything all over again from the beginning of the procedure. Okay, patient prep is pretty self-explanatory, an empty bladder, and I think everybody's aware of the equipment that's required to do this ultrasound. Okay, so before the procedure starts, you're going to review any of the order and any prior imaging, making notes of any abnormalities that might require further evaluation. You're going to do your PPI. You're going to check their name and the birth date with your order, your documentation, your papers, and your screen. You're going to collect any clinical information or history that's relevant, including any symptoms and their last menstrual period. Any allergies, depending on, to the gel or if you're using a latex probe cover. I know there's not very many right now, but I think Credit Valley had some latex still. You're going to explain the procedure and get informed consent from the patient. Okay, so to do the probe insertion itself, you're going to follow the probe reprocessing SOP, the pre-procedure steps. I think everybody's familiar with that SOP and getting it from the bin. Again, you're going to ask the patient if they want to put the probe in themselves. If they do, make sure that they have performed hand hygiene. If you're doing the probe, you're going to do hand hygiene. And again, you probably already have done hand hygiene, but you're going to do it again and put on gloves immediately before putting in the probe. The patient should be positioned supine with their knees bent and feet flat on the bed. And then you can elevate their hips or pelvis as required. Apply gel into the probe cover, cover it with the the cover, the condom, and apply the single package lubricant to the probe cover. If you need a light source to be able to visualize the anatomy correctly, then you will use light source and position it so that you can see. You will insert the probe 5 to 10 centimeters approximately. If, again, the probe comes into contact with the rectum, do not proceed to try and reinsert that probe. You must exchange the soiled probe for a clean probe and start the process again in step 1 down to step 10. Okay, once the probe's inserted, you can turn off the light source if you had used one. Okay, so I'm just brief going to say this because Dr. Bruni is going to talk a lot more about the technical considerations in the imaging, but I only have one more slide left. So obviously you're going to document all of your examination, including any measurements, any additional images that are necessary to document the pathology, you're going to complete. And if you have any significant or urgent findings, check with the radiologist. And prior to leaving to check with the radiologist, if you're going to leave the room, please remove the probe and don't leave it in the patient while you go and talk to the rad. Okay, so post-procedure, remove the probe, follow the reprocessing, the post-procedure steps, and leave the room nice and tidy. For documentation, you're going to complete the female pelvis worksheet or Sinultra. And again, if you did not do a transvag ultrasound, that is documented on that worksheet. The reason why, scan all of your worksheets and information into packs and your info to packs, assign your rad, perform your tech QA, make sure you're not missing any images, make sure all measurements and annotations are completed and correct on your imaging, and then finish your documentation in Epic, including, again, documentation of the medical directive if you use that, or that the patient inserted themselves and completed hand hygiene. Okay, I did that pretty fast. Does anybody have any questions? I should say Dr. Bruni's going to talk about the fun stuff, the imaging, but do you guys have any questions for the legislative or the medical directive or the SOP? No? Okay, I am going to stop sharing then and hand it over to Dr. Bruni for the imaging.
Thank you so much, Kim. I'm just going to pull up our slides here. All right, everyone can see my screen okay? I'm going to assume that that's a yes. I haven't heard any no's. Okay, perfect. So just to go over the imaging portion of the revised SOP, again, similar to most of the SOPs that we went over during our last in-service, a lot of this is not a dramatic departure from what we're all normally doing already, but some additional details have been included in the SOPs. So at your leisure, please go through those and just take a look. But we'll highlight some of the key revisions here during this presentation. So in terms of the pelvic examination, female pelvic examination, kind of divided into either the transabdominal and/or the transvaginal portions. There's separate SOPs for the pelvic exam, just strictly transabdominal, and then the transvaginal has its own dedicated SOP. There is quite a bit of overlap, obviously, between those two. But I think that the main thing to stress here is that for the transabdominal images, if it's anticipated that you're going to be going on to a transvaginal examination, that is that there's no contraindication and transvaginal examination is indeed indicated in that patient, then the transabdominal study is slightly more truncated than if a transvaginal examination is not going to be performed. So generally for the transabdominal images, obviously this should always include your midline sag and mid-body transverse images of the uterus with 3D measurements. If you anticipate that a TV study is not going to be done, then you should include parasagittal images of the uterus as well. So left parasagittal, right parasagittal, as well as sag images of the cervix and transverse images kind of sequentially through the uterus, including the fundus and lower uterine segment. Again, in your routine transabdominal images, transverse and sagittal representative images of the bilateral ovaries if visible, or the adnexa if they're not. I would suggest taking sequential images through the adnexa if you don't definitely visualize the ovary and you don't anticipate you're going to go on to a transvaginal study because it's not particularly indicated in that case. And then again, in terms of the 3D measurements and color Doppler, I would say try to perform them kind of limiting the need for them on transabdominal images if you anticipate that you will be going on to a TV exam and that you anticipate that they will be seen or better seen on the TV exam. If the ovaries are high or you're not performing a TV, then these 3D measurements and color Doppler evaluation of the ovaries should be performed on the transabdominal study. Additionally, it's a little bit of a departure from what we usually did, but if the uterus is markedly enlarged, say the size of a 20-week gestational age gravid uterus or anything larger than that, or there is otherwise a large pelvic mass that you encounter during the TA examination of the pelvis, sagittal views of the kidneys should be included to assess for any associated hydronephrosis. So that's not something we've routinely done before, but it should be included as part of your examination if you do encounter that abnormality. So moving on to the TV images, again, similar to what we already do and similar to what is already done in the transabdominal portion of the study, uterus, sag midline and parasagittal images, as well as the transverse through the fundus body and lower uterine segment. Sag and transverse images of the cervix and posterior cul-de-sac, looking for any free fluid in that region. And then representative images, transverse and sag of the ovary without and with 3D measurements, and then with color Doppler examination as well routinely. If the indication specifically is for pain, pelvic pain or abdominal pain, query torsion, or if the ovary is abnormally enlarged or heterogeneous or any other abnormality of the ovary is detected, both arterial and venous spectral Doppler waveforms need to be obtained. So these don't routinely need to be obtained in the absence of these particular indications, but a color Doppler image of each of the ovaries does need to be obtained routinely in all cases of transvaginal pelvic exams. If you detect, in terms of tenderness during the examination, this should be documented if there is any tenderness, and if there's a particular region that the patient experiences more significant tenderness during the transvaginal examination, images of that particular region should be obtained with documentation on the image or on the worksheet indicating that is the region of maximal tenderness. So in terms of when a transvaginal examination should be performed, regardless of whether or not it was ordered by the ordering physician, unless it's particularly contraindicated or obviously declined by the patient, this should be performed in these 8 circumstances. So if the endometrial stripe appears heterogeneous or a portion cannot be seen on the transabdominal examination, specifically in a patient with a history of abnormal uterine bleeding, or if the endometrial thickness is greater than 5 millimeter in a postmenopausal woman, that is an indication to include a transvaginal examination if it's not specifically contraindicated. If there is a request from the on the ordering requisition to specifically evaluate the ovaries, or to better evaluate a ovarian cyst or lesion that's seen on the transabdominal study that's not particularly well characterized on the transabdominal study, that should require a transvaginal exam. To better evaluate any significant pelvic pathology, although this excludes fibroids, if there's no abnormal uterine bleeding, or to characterize any free pelvic or adnexal fluid, if the question is blood, debris, or septations on the transabdominal study. So if it's not specifically just free fluid, or sorry, simple free fluid, that should be further characterized with transvaginal examination. Early intrauterine pregnancy where the gestation is not well seen transabdominally, unexplained lower abdominal or pelvic pain, in the absence of a cause that's specifically seen on the transabdominal study, or for investigation of possible pelvic GI pathology that again is not well characterized on the transabdominal study. So, rule out appendicitis versus PID, sigmoid diverticulitis. If a pelvic examination is requested and something is seen on the transabdominal that may be better characterized on the transvaginal exam. Kind of this is a bit of a duplication of number 3, but unexplained or particulate ascites. So again, anything beyond the normal, simple, likely physiologic free fluid that should go on to further characterization with TB. Any evaluations for ectopic pregnancy, and poor visibility of the pelvic viscera on the transabdominal study for whatever reason. Again, if there is any questions, whether or not in specific circumstances, whether or not a TV is particularly indicated, obviously, after the transabdominal study, just contact the radiologist and they can direct you further if there is any other complicating circumstances that are outside of these indications. So in terms of some technical considerations and some other modifications from what we normally do, in the absence of a study that's done specifically for surgical planning of fibroids, when you do encounter multiple fibroids, only the 2 largest and any submucosal fibroids need to be documented. So I know we tend to record every fibroid we see, and by all means you can continue to document those, but in terms of actually putting calipers on and measuring the fibroids, really only the 2 largest are needed. And again, any submucosal fibroids as those may be a cause of abnormal uterine bleeding or can cause issues with future pregnancies. So those 2 need to be documented, but for any intramural or subserosal fibroids, really only the 2 largest need to be recorded on the tech worksheet. You can just write that there are other small fibroids beyond that if you so wish. In terms of endometrial thickness, this obviously needs to be measured on a SAG image and include both layers. One thing that I see done kind of inconsistently is if there is any fluid within the endometrial cavity, this needs to be excluded from the endometrial measurement. And in those cases, put calipers on each individual layer and then sum the values of those 2 layers to get the double wall thickness if there is fluid splitting the endometrial lining. In terms of ovarian imaging, if the ovary is in an abnormal location, this needs to be documented again, either on the image or on the tech worksheet as abnormal location of the ovaries, such as a location within the posterior cul-de-sac, may indicate ovarian displacement either in the setting of torsion if the ovary looks abnormally edematous and hypovascular, or potentially tethering due to endometriosis or other causes of peritoneal adhesions. Often in cases of endometriosis, you may also notice that the uterus is abnormally retroflexed, so it may be anteverted, but the fundus is pulled backwards by that tethering that often occurs within the posterior cul-de-sac, and the ovaries may be also tethered into the posterior cul-de-sac and can be kissing occasionally as well. So, and a lot of these patients that come in with chronic pelvic pain, you may see that they've had multiple sonographic or CT investigations for abdominal and pelvic pain going back multiple years. You can occasionally see these findings, and it may indicate a background of endometriosis where the endometriotic plaques are just not well appreciated on ultrasound, and they typically aren't. But important to document that location of the ovary. Again, document images at sites of significant tenderness, as I mentioned before. In terms of documenting cysts within the ovaries, simple cysts or functional cysts, only the largest on each side needs to be measured, but important to adjust your gain and other technical parameters to demonstrate the simple anechoic nature of the ovary. Just clear it up as much as possible. I know it's not always possible, and there may be some haziness and what looks to be internal echoes, but it may be entirely technical in nature. If that's the case, then document that on the worksheet as well. In terms of complex ovarian masses, obviously needs to be assessed for internal septations, any mural nodules or papillary projections. If you do encounter any mural nodularity or papillary projections, as well as any internal septations, color, and I would suggest throwing on power Doppler as well as color Doppler to assess for any faint vascularity within either septations or nodules. In terms of exophytic ovarian or paraovarian adnexal lesions, this is something, again, inconsistently done, but very, very helpful for the interpreting radiologist. Please include a cine loop for a paraovarian lesion or an ovarian lesion to demonstrate if the lesion moves with the ovary and suggests that an exophytic ovarian origin, or moves separately from the ovary, the so-called sliding sign that would confirm a paraovarian location. This is critical for ectopic pregnancies, as corpus luteum cysts look very much like a ectopic adnexal paraovarian lesion, or can look like that if it is a bit ectopic, or sorry, if it is a bit exophytic. And that sliding sign showing that it moves separate from the ovary is very strong support of that lesion being an ectopic pregnancy rather than a exophytic corpus luteum. So that is all of the slides I had with regards to the revised SOP for the pelvic, or for the female pelvis. Before we go on to the additional SOPs that we didn't get to the last month, is there any specific questions with regards to the female pelvic SOP? So I just see one question from Shalinder. So with regards to OB studies for transvaginal insertion, I'm still in the process of getting feedback in terms of the transcervical and early first and second trimester SOPs. So I'll have to put a pin in that in terms of where transvaginal is broadly indicated or indicated without consultation with the radiologist. But in the interim, I would say continue doing what we routinely do for those cases. And obviously, again, if there's any questions, just consult the interpreting radiologist that day, and I'm sure they'll let you know whether or not we need to go on to TV. But I'll try to avoid addressing that any further, just because I don't want to confuse things if I say something now and then we decide to change how the SOP reads for the OB examinations. If there's no other questions with regards to the pelvic exams, I'll just go on to the couple last SOPs that we did already approve. So there's just a couple of other pelvic exams. So the groin pseudoaneurysm / arteriovenous malformation, arteriovenous fistula study, as well as the hernia study. So in terms of the groin pseudoaneurysm SOP, a little bit more extensive description of what images need to be obtained are now within that SOP. So again, at your leisure over the next couple of days or week, just try to take a look through those SOPs to get a more extensive look at what images are required. But in brief, essentially a long grayscale color and spectral Doppler image of the vessels within the groin, including the common femoral artery, the CFA, so the common femoral artery, from the distal external iliac artery through the proximal superficial femoral artery, so essentially the entire length of the CFA. Long images, again, grayscale color and spectral Doppler of the common femoral vein. Notably, if you encounter arterialized waveform within the vein on your spectral Doppler examination, really look closely for a potential AVF, as really there shouldn't be an arterialized waveform within the venous structure. So if that is present, it highly suggests that there is an AVF, which can be quite subtle, but if you look closely, you should be able to find it. Color Doppler can be particularly useful in looking for a subtle arteriovenous fistula that may be essentially a cult on grayscale imaging. And that's normally going to be picked up as turbulent flow disturbances, which will generate a color Bruni surrounding the fistula within the surrounding soft tissues, and then that aliasing within the representing that turbulent flow within the fistula itself. So if you detect the other thing, if you detect any thrombus within the common femoral vein, obviously split screen grayscale images without and with compression, if you do detect any thrombus, as you would with any DVT study. Aside from that, transverse images in, again, grayscale and color Doppler need to be obtained kind of sequentially through the common femoral artery and vein at the level of the puncture site, and then a couple of centimeters above the puncture site and a couple of centimeters below the puncture site, just kind of going through that level, again, looking for any surrounding hematoma, pseudoaneurysm, or AVF. If there is a closure device that was used or is seen during the examination, this needs to be documented and imaged. So usually that'll show up as a linear echogenic structure with relatively dense shadowing, or if that's explicitly noted in the indication or post-procedural documentation, it should be noted on our exam as well. So here, just an example from the literature showing an arterialized wave. Well, it doesn't show the arterialized waveform, but it does show this abnormally turbulent flow of a AVF between, in this case, this is a brachial artery and brachial vein, but the AVF should look the same in a common femoral artery and vein. So again, aliasing from that high turbulent flow, and here you can see that color bleed from the Bruni bleeding into the surrounding soft tissues. So this abnormal colored Doppler signal in those adjacent soft tissues. So if a pseudoaneurysm is identified on exam, grayscale and color Doppler images of the aneurysm and any surrounding hematoma needs to be documented, as we already normally do. The aneurysm sac, that is the vascularized lumen, should be measured in 3 dimensions. So this is the anechoic portion that when you put on color Doppler flow, will have that yin-yang classic to and fro Doppler flow. A cine image can be recorded showing that to and fro flow, which can be nice to conclusively show this to be a pseudoaneurysm. And then obtaining a spectral Doppler waveform within the sac, not as critical, but while you're in the area, easy to throw on just a caliper in that region and obtain a short waveform. If there is any surrounding hematoma around the pseudoaneurysm, which there often is, that should also be measured in 3 dimensions, just for follow-up. And then any between the artery and the aneurysm itself should be measured in terms of the length and width of the connection to that parent vessel. So there is a new pseudoaneurysm worksheet that can be used for all of the things that we've kind of gone over in the revised SOP. Again, the hematoma size, pseudoaneurysm size, and pseudoaneurysm neck size, the vessel of origin, which is often going to be that common femoral artery, but if you do happen to see it and it traces down to, say, the proximal SFA or potentially higher up into the external iliac artery, then that can be documented here as well. If there is a closure device that's seen, whether that's present, and then the common femoral vein flow. So moving on to the groin hernia SOP, they're actually both housed within the same SOP, but separated out into 2 different sections. But essentially similar to what we normally already do, long and transverse images of the hernia sac, with and without with measurements if the sac is present, transverse measurement of the hernia neck, and then side-by-side split screen images in grayscale without and with Valsalva. And if the hernia sac does appear to move on Valsalva or doesn't move on Valsalva, a cine loop should be obtained during that Valsalva. Obviously, if the patient's unable to perform Valsalva, you can instead do side-by-side images with the patient supine and then standing. If the hernia is normally there without Valsalva and is reducible with probe pressure, then a cine loop can be taken while applying transducer pressure to demonstrate this reducibility and should be documented as such. One thing that I think is inconsistently done a bit, or is done at some sites, but not done routinely at other sites, and I think we need to start doing routinely across the board, is if it is an inguinal hernia that's detected, the relation of the hernia sac to the inferior epigastric vessels needs to be documented with color Doppler and arrow annotation and on the screen if it's not entirely clear where those vessels are. And I'll go over quickly kind of the importance of that and how we determine direct versus indirect hernias using that information. If herniated bowel is seen within the hernia sac, obviously routinely we need to assess for signs of incarceration. So things that would suggest incarceration would be decreased flow within the bowel wall. So throw on color or power Doppler to indeed document vascularity within the herniated bowel. A cine loop demonstrating peristalsis if the small bowel loop is peristalsing, which it should be if it's not incarcerated. If it is strangulated and is starting to become ischemic or is otherwise obstructed, you may not see peristalsis, which should also be documented in some way, either by cine loop or just by writing on the tech note that it is not peristalsing. And then the bowel wall thickness, generally less than 4 millimeters, and lack of any surrounding inflamed fat or fluid would suggest that it's not incarcerated. Presence of those findings would suggest potential incarceration, although free fluid is obviously a non-specific finding and may be related simply to acidic fluid for some other reason that's also herniated into that bowel, into that hernia sac. And then other thing that needs to be documented is any changes of the overlying skin or tenderness while scanning over the hernia, as we routinely already do. So in terms of the different types of hernias within the groin that can be routinely encountered, the main three are going to be your direct and indirect inguinal hernias, and then femoral hernias, which are much more rare than the two inguinal hernias. So distinguishing between those indirect, direct, and femoral hernias really has to do with the relation to the inferior epigastric artery within the anterior abdominal wall, and also the relation to the femoral vessels and inguinal vessels, or sorry, iliac vessels rather. So in terms of the three types of common hernias, hernias that lie anterior to the external iliac vein and superlateral to the the IEA, which would be the inferior epigastric artery, are classified as indirect. Those descend into the scrotum through the deep inguinal ring and then course anterior to the spermatic cord within the inguinal canal within males, or follow the round ligament in females. So here you just have a pictorial representation of that on the right. So here you see the hernia sac extends through the patent processus vaginalis that doesn't close during development. Normally that would close, but if it remains patent, you can have herniation of bowel contents through that deep inguinal ring, and that occurs lateral to these inferior epigastric vessels. So the hernia sac will lie lateral to them and will lie anterior to your external iliac vessels and common femoral vessels, and then will descend within that inguinal canal, lying posterior to the spermatic cord. Whereas here on the left, you have an example of a direct hernia where the viscera bulges through Hasselbeck's triangle, which is a weak point within the posterior wall of the inguinal canal. And this type of hernia will localize medial and inferior to these inferior epigastric vessels, and will descend within the inguinal canal posteromedial to the spermatic cord if in a male. Sorry, I think I said posterior to the spermatic cord in the indirect, but that this should actually be anterior to the spermatic cord, in contrast to the direct, where it's often posterior to the spermatic cord. Far and away, the indirect hernia is going to be much more commonly encountered. It's 7 times more frequent than the direct type of hernia. So you're often going to see these indirect hernias occurring lateral to the inferior epigastric vessels much more commonly. The final type of hernia that really we don't encounter all too often is the femoral hernia, and these are going to occur more inferior than the inguinal hernias, and that's going to be like one of the biggest differentiating factors, generally inferior to the inguinal crease, and are seen medial to the common femoral vein, which is usually laterally displaced and compressed by that hernia sac. So these are more often within if you do encounter that finding, the hernia sac is likely within the femoral canal itself, and is classified as a femoral hernia. So these hernias are more commonly seen in females, but again, generally much more infrequent than your inguinal type hernias, and generally are going to be located in the anterior thigh, lower down, relative to where you would find these inguinal hernias. So here's just a couple of examples from the literature, just showing some correlates for what you may see. So here we have an indirect inguinal hernia where it's a little bit harder to demonstrate on a single image the relation of the hernia sac relative to the inferior epigastric vessels, just because the course of the hernia neck is generally oblique to the long axis of these vessels. So it's a little bit hard to kind of show again on a single image, but here those internal iliac vessels are seen, and this hernia sac is extending lateral in this patient. This is a left-sided hernia sac, so by convention, this is going to be lateral to these vessels. So it's also important to, again, use convention in terms of your probe orientation in all of these cases, so that this relation is made clear. Here, again, this is a direct hernia. And here you see in cross-section your external iliac vessels down here, and then the inferior epigastric vessels more superficially that are traced from the external iliac artery. And the hernia sac, in this case, again, is on the right side of the patient, and these are occurring medial to the inframedial to the hernia sac. So direct hernia in this case. So just want to quickly see if there's any questions or comments about those last few SOPs. If anybody does think of anything later on, again, feel free to email, call, find me at the hospital, and we can go through anything that you do have any questions about or concerns about. If there's no other questions, we have a few more minutes, so I thought maybe we can go over a couple of interesting cases in these last few minutes. So I guess there's no other further questions. Okay, so we'll go over what we can. And then I still have a few more that people have sent to me and that I've collected that we can try to go over at our next in-service if we do have any additional time, or if we just want to do an interesting case rounds for our next in-service. So just to start, quick case. for a young patient that was seen a couple of weeks ago at M site. 7-year-old male, acute onset of crampy periumbilical abdominal pain, single episode of vomiting, some abdominal distension, classic QWERTY appendicitis, and that's what the patient was sent to ultrasound for. So I'm just going to pull up the images here. So just want to make sure everyone can see the PAC screen. Okay, so I'm going to assume that everyone can. So essentially what we have here, right lower quadrant, we did find the appendix. And as you can see, measurements a bit up. I think if you actually measure outer wall to outer wall, it's probably in the order of about 6 millimeters, so kind of borderline upper limits of normal. And depending on where you take it, it is around that upper limit of normal 6 millimeter. But one thing that you notice is that there really isn't much in the way of significant. Oh, okay, so you can't see. All right, so you should be able to see it now. So again, just gonna wait for my computer to respond. There we go. So here we have the appendix in cross section. Again, measures up to about 6 millimeter outer to outer, but really not much in the way of surrounding inflammatory changes. Patient wasn't substantially tender within that right lower quadrant while scanning over the appendix. You can see some internal echogenicity, some gas with some dirty shadowing behind it within the lumen of the appendix, which isn't frankly distended and is actually, if anything, mostly collapsed with the exception of those locules of gas. And we do have a nice cine loop through that appendix tip, at least. Again, showing it a bit borderline thickened, but otherwise preserved sonographic gut signature and lack of surrounding abdominal, or sorry, surrounding inflammatory changes. So just going back to the slides here. So this is what I suspect a case of lymphoid hyperplasia of the appendix. So histologically, this is defined as clusters of greater than 10 lymphoid nodules, each of which contain lymphoid follicles greater than 2 millimeters in size. And those lymphoid nodules are generally in response to inflammation within the adjacent structures. So various inflammatory conditions could cause this, viral gastroenteritis, colitis, mesenteric adenitis, things that can occur either throughout the abdomen or specifically within the right lower quadrant. And it causes the lymphoid tissue within the bowel to become essentially hyperplastic with these multiple nodules. So this is much more frequently seen in the pediatric population than the adult population, but can often occur in the adult as well. But again, a very common mimic for acute appendicitis in the pediatric population, as it does generally cause thickening of that lamina propria, and the overall outer diameter thickness of the appendix can become borderline to minimally thickened. So generally what you will see is an appendix that's 6 to 8 millimeters, does not often get greater than 8 millimeter. If you see an appendix that's larger than 8 millimeter, this is unlikely to be the cause of abnormal thickening of the appendix. But in that 6 to 8 millimeter range can be a false positive for appendicitis. That being said, even if you see this 6 to 8 millimeter thickening with that classic thickening of the lamina propria, hypoechoic thickening of the lamina propria, this can also be complicated by a superimposed acute appendicitis on top of the lymphoid hyperplasia. And in fact, that acute appendicitis may be the cause of the lymphoid hyperplasia. So really, when you're trying to make the diagnosis of lymphoid hyperplasia, really you need to see the absence of those secondary sonographic findings that you would see generally with acute appendicitis. So specifically wall hyperemia, which again cements the importance of having color and power Doppler images of any thickened, abnormally thickened appendix, as well as those periappendiceal findings, so periappendiceal fluid or inflamed echogenic fat. So here, just a couple of correlate cases from the literature showing the classic appearance of the lymphoid hyperplasia of the appendix. So a mildly thickened appendix, in this case on the left, up to 7.6 millimeter, on the right up to about 6.4 millimeter. But again, the thickening of the appendix is largely in both of these cases related to this uniformly hypoechoic thickening of the lamina propria, which is a layer of the mucosa, and then the echogenic submucosa is pushed out to the periphery and is generally a little bit compressed. The lumen as well is also compressed and may be filled with a couple of discontinuous locules of echogenic gas with potentially some dirty shadowing if there's enough of it. Here, also some companion cases of complicated lymphoid hyperplasia. So here on the left, you see a case where the appendix is thickened, but again, relatively uniform, not particularly hyperemic, not much in the way of surrounding echogenic inflamed fat. It's not the greatest image, unfortunately, but then at the tip, you start to lose that normal gut signature, some hazy hypoechogenicity into the normally echogenic submucosa, and then surrounding periappendiceal echogenic inflamed fat and hyperemia within the appendiceal tip. So this is a tip appendicitis with concomitant lymphoid hyperplasia. Same thing on the right here, normal gut signature through the body of the appendix, but that abnormally thickened hypoechoic lamina propria, and then into the tip, you start to lose that gut signature, hazy hypoechoic edema within the normally echogenic submucosa, surrounding echogenic inflamed fat. No color Doppler on this case, but this again is compatible with a tip appendicitis, but also has this lymphoid hyperplasia. So the main takeaway here is that in the pediatric population, you may encounter these borderline thickened 6 to 7 millimeter appendices without periappendiceal signs, secondary sonographic signs of acute inflammation. Patient may not be particularly tender over the thickened appendix. And if it does have that thickened hypoechoic lamina propria, this is a very good look for lymphoid hyperplasia, and it can be raised on the basis of those findings. So that takes us 5 minutes beyond 1. So I think we'll wrap it up here. I'm sorry we only got to the one interesting case, but hopefully it's something that some of you haven't seen before, and you can take away for practice going forward. And we have a number of other nice cases that have been submitted as well. So hopefully we'll get to those at our next in-service. Again, if you do come across any interesting cases in the coming weeks, please record the MRN or accession number, email it to me or send it to me through Sectra, and we'll get to them in our next or in future in-services as well. And again, as an aside to that, I am going to try to get all sonographers access to teaching files through Sectra, the ability to add cases to teaching files, which I don't believe you currently have. So that will make this process a lot easier and will facilitate future learning through shared cases. All right, thanks all for your participation, and I'll see you all at our next in-service.